Okay, while we're waiting for people to continue joining, we'll just get a very brief introduction and overview. So first of all, thanks everyone for joining, and whichever time zone you're in, we know we have people from all over the United States and the world who are planning to join, which we're really excited about. Um, as a little bit of background, we have a webinar series called Let's Talk MPTs, and this is today's topic is on social behavioral research. I'm Clara So. I work for CAMI Health. We house the IMPT, which is the secretariat that coordinates the field for MPT research. And I'll give a very, very brief overview of MPTs for people who are not familiar with this particular acronym. So just a very brief overview and just some logistics while we're continuing to see people enter the webinar. We're going to ask everyone to stay on mute during the webinar and then use chat for questions. We sometimes have actually a lot of very interactive chat in the background during the webinar itself and then for Q&A afterwards. After the two presentations, we'll open the floor to questions for everyone. So you can either put your questions in the chat if you don't feel comfortable voicing them out loud, or you can also unmute and ask a question. We also have a couple questions that we have from beforehand that the CAMI Health staff will be asking the moderator or asking the presenters. So just a couple of those logistical questions, and then yeah, we're ready to get started. So you could go to the next slide, please. So a very brief overview of today's webinar. Again, we're going to welcome and thank you all for joining for this really exciting topic. I think it's going to be really interesting and educational, especially for a lot of product developers who have we know some product developers have gone fully in and done a lot of end user research, and others who are just sort of towing the water. So I think this will be really good for everyone. And this is something where we also are really trying to help incorporate more into the field. So hopefully from today, you'll also get some resources to understand how you could do this kind of research, or where you can reach out for more expertise if you're interested in building some of this work into the work that you're doing yourself. So today we're really, really excited to welcome two fantastic speakers. We have Dr. Rosalind King, Roz, who works for the National Institutes of Health in the Office of Behavioral and Social Science Research. And we also have Dr. Teri Senn, who's with the National Institute of Mental Health. Again, following their presentations, they'll both talk for about 20 minutes, so 40 minutes total. We will open up the floor for discussion, and both myself and Bethany, our executive director of CAMI Health, will be facilitating the discussion. Following that, we'll just have like a little bit of a wrap up. We'll talk to you about some next steps, other resources that you can also access via our website. So if you don't mind going to the next slide, please. Thank you. So, okay, I hope and believe that many people are familiar with MPTs, but if you're not, I just wanted to briefly mention that this is the acronym for multi-purpose prevention technologies. These products aim to combine contraceptives with anti-HIV or other STI preventatives. So again, I think I mentioned that CAMI Health houses the IMPT Secretariat, and we work to coordinate and serve as a central hub to many MPT-related activities and learnings. Broadly, as you see on this slide, our mission is to foster an enabling environment for the successful advancement of MPTs for women around the world. So in order to do that, we serve as a learning network. We sponsor events such as this, where people can learn more about research, ongoing research, new developments, or other research that you might be able to incorporate into your own work. And we also have identified 5 broad action areas to advance our mission, which are found on our website. And this is the first webinar for this year, and we're planning at least 3 more, so usually once a quarter. So we invite you to attend those and look forward to more engaging webinars. Next slide, please. So just a little bit more background on CAMI Health and the IMPT before we get to the meat of our presentation today. We maintain on our website the MPT product development database, And so this is a database with all of the products that are currently under development. Also, in the past year, we started listing archive products that are no longer under development, so we can learn from the past science as well. On this database, you can filter by delivery type, indication, and where each product is in the product development lifecycle. And I also wanted to give a big shout out to Madison, who is helping to run our Zoom webinar today, who also does the brunt of this work, keeping this database up to date. So the one thing I also wanted to mention is if you're a researcher or even a funder and you don't see your product listed, please reach out. So we usually do a major refresh once a year, and that will be coming up about next month. We'll start that process. So this is a great time to give us more details, make sure you're included, and make sure everything we have is accurate. So next slide. The last thing I'll mention about the work that we're doing is that on our website at theimpt.org, we also have a social behavioral research hub, and among the many other resources that we have, I'm just mentioning this one because it's directly related to the subject of today's webinar. We do strive to keep this hub up to date with the latest research, tools, and other media to help keep end users in mind throughout the entire product development lifecycle. So again, we will have a recording of this webinar archived. We'll also have copies of presentations available. And we invite you to also visit the SBR hub on our website to find out more information and tools that can help you with this work. So next slide, please. Okay, so this is what you're all here for, to hear from Roz and Teri. So I just wanted to very briefly introduce them, give a little bit of overview, and then hand it over to them. So Dr. Rosalind King is the Section Chief for Scientific Development and Coordination at the National Institutes of Health, Office of Behavioral Research and Social Sciences Research. Her research has been centered around behavioral patterns of contraceptive use, the intendedness of pregnancy, and the use of reproductive technologies. For this presentation today, Roz will be providing a bird's eye overview of perspectives from social and behavioral sciences that have implications for end user research in contraception across multiple domains with examples for selected topics. Roz will discuss how people's contraceptive and preventive health choices interact with other environmental and policy factors such as life course stages, access to healthcare, and demands of daily life. So she's going to give the broad context of how these decisions are made. And then following her, Teri is going to be drilling down a little bit more. So she'll be talking while we have this overview of the context in which many individuals are making these choices, Teri's actually going to give us a discussion around the behavioral science methods that have been used in HIV research, both in treatment and prevention, to elicit end user preferences. As you may know, HIV preventatives are a major component of many of the MPT candidates under development. So this is going to pair really well with the talk that Dr. King is going to give about contraception. Dr. Senn is a program chief for psychosocial comorbidities of HIV prevention and treatment, and will also help us better understand who end users are. So spoiler alert, you may be surprised. She'll also help us understand why we should care about end users, and we'll discuss the 5 major methods for assessing end user preferences, such as human-centered design and discrete choice experiments. And just on a personal note about end user preferences, for the last 5 years, I was a full-time rock climber, and I just gave an interview to a outdoor-focused publication, and they asked me what my favorite piece of climbing gear was, and I said my IUD. And it was like mic drop. And I don't think when product developers were creating the IUD that this was a use case that they had ever thought. So this is another case where, sometimes end user preferences are not what you may think they are. And the reasons people use certain products, especially around contraception, fertility, and things that are so personal, can be really different than what you think. So I hope we all learn a lot. And now I'll turn it over to Roz.
Thank you, Claire, for that great introduction. And I love that rock climbing story. That's fabulous. So let me do some clicking. All right, y'all are seeing the presentation? Yeah?
Yes.
Okay, Thank you. All right. So good morning or good afternoon, depending on where you are. I'm Roz King, and I'll be speaking on social and behavioral considerations in product development research for multi-purpose prevention technologies. I'm a social demographer, and my training is in human behavior patterns around fertility management. And my research has really been focused on contraceptive use in the US. So my talk is slanted in that direction, but I'm happy to toss around ideas about other contexts during our Q&A period. So, all right. So I'm going to give a high-level view of considerations about human behavior that are relevant to product development through a social and behavioral sciences lens. I'm not addressing medications and devices specifically. But what I'm going to do is provide theoretical and methodological concepts about how you can think of MPTs as a category of technology and as a type of intervention, and using these scientific perspectives to incorporate into your product development efforts. So social scientists consider how people use technology through their daily experience in the context in which they live. So as an example, what's simpler than making a morning cup of coffee? Well, the first thing to note in this example is that I'm projecting a majority preference onto all of you with that question, and it's admittedly my preference, my own bias as a researcher. There are cost considerations to that cup of coffee. There are aesthetic considerations to these different kinds of technology to make it. They're both input and output considerations, from the ingredients to the final beverage that you select. Some people just want to outsource all of it. That's a coffee shop at the end there. Or they might lack access to a place to use the technology within their home, depending on their living situation. And some people just really have no use for a coffee maker or any coffee at all. So social considerations for the use of technology should always incorporate ethical principles. And for MPTs, one important framework that is surrounding all of your work is the emergent emphasis on reproductive justice. And I'm quoting here from the Reproductive and Sexual Health Equity Framework put forward by Christine Dellendorf of UCSF and colleagues. The framework requires of us these 2 points, among others, in our research: that we acknowledge historical and ongoing harms, including those perpetuated by healthcare and public health institutions, the coercive sterilization of women of color and women with disabilities throughout the 20th century, the systematic removal of Native American children from their families, unethical testing of the oral contraceptive pill in Puerto Rico in the 1960s, and targeted marketing of the contraceptive injection in the 1990s. As well, we must honor bodily autonomy for all people, recognizing that there has been resistance to removal of long-acting reversible contraceptive methods by healthcare providers. Another framework advanced by the NIH, Healthy People 2030, and others is that of the social determinants of health. This table comes from the National Institute of Minority Health and Health Disparities, one of the NIH's 27 institutes and centers. Across the top are levels of influence from the individual to societal. Down the side are domains of influence from within the individual body outward to the healthcare system. And I've picked 3 of the cell intersections as brief examples for today. So the framework also notes along the side the importance of considering the life course, which is particularly important for the intersection of the biological and the interpersonal. The female reproductive lifespan is anchored at one end by menarche and the other end by perimenopause. In between, individuals experience their first intercourse and sexual relationships. They enter into unions within which much, but not all, childbearing takes place. Individuals and couples engage in spacing behavior between planned childbearing events, if they are planning. Once they're satisfied with their family size, they engage in stopping behaviors with the possibility of restarting the cycle if they enter a new union. And finally, perimenopause brings new uses for contraceptives, such as maintaining the regularity of menses and managing symptoms. So these interweaving contexts shaping changing needs and preferences around MPTs can encounter additional complexities. 2 examples are considerations by sex gender identity and disability. This first quote is from Higgins and colleagues' work on contraceptive use among lesbian and queer women. For me personally, if I wasn't planning on having sex with a man, it would be too much of a hassle to go out and get an IUD. You'd have to go to a doctor and make a doctor's appointment, and that's a lot of work. The second is from Gigi Diffieb's dissertation on sexual and reproductive health care for persons with disabilities, which can result in a challenge to full control over one's own decision-making. I was living with a family who were taking care of me, who had a lot of oversight over the medications I was taking and what I was putting in my body. I was getting pushback, especially from one person who doesn't trust doctors, doesn't trust medication. That's why I wasn't on the pill for a couple of years after I got injured. And I included this slide to give a shout out to my colleagues at the Centers for Disease Control and Prevention. This is a page from their website and furthers the effort to recognize persons with intellectual disabilities as valid end users for your research community. So at the intersection of the behavioral and societal lie policies and laws such as insurance coverage. The ACA, the Affordable Care Act, guarantees coverage of women's preventive services, including free birth control and contraceptive counseling for all individuals and covered dependents with reproductive capacity. And the ACA goes on to list a series of methods. But this is not a panacea. There's no coverage for male methods. There's no requirement for individuals to participate in the ACA. That mandate is gone. So not everyone has this coverage. And then even among those who are insured, researchers have documented gaps in compliance by employer-sponsored plans and gaps in Medicaid coverage. At the intersection of the health system and community lies the availability of services. Policies and laws operate at the level of what could be possible. The availability of services addresses what you can actually get. So as Swan notes, by influencing the location and density of health facilities and their ability to provide adequate appointments and services, policy also impacts people's ability to physically reach contraceptive care in a timely manner. And so in this research, Mihoza and colleagues examined trends in stockouts, method availability, and consumption of specific contraceptive methods in urban areas of 4 sub-Saharan African countries, Burkina Faso, Democratic Republic of Congo, Kenya, and Nigeria, and India, by insurance type, public, private, and all. And I realize this is really hard to see. It's a great article, and the link is there. But I just really want to show this for the patterns at this point. Yellow is where, when this is for injectables, they include these graphics for multiple types of contraceptives. Yellow is not offered. Red is currently out of stock. Light blue is currently in stock, but was out of stock in the last 3 months. And dark blue is currently in stock and no recent stockouts. So you can see, really interesting things in the patterns here. For example, yellow sometimes varies by source of insurance. Red generally impacts both groups when it happens, those are the stockouts. And so, this really emphasizes the difference between policy and the real world. So one way to think about end users in their real world contexts, such as geographic locations, is to group them into populations rather than consider them as individuals. So this definition of population comes from my former branch where I used to work at NICHD, the Population Dynamics branch. In population research, population is defined as the aggregate collection of individuals defined either geographically or demographically. Examples include the residents of New York City, married people in the US, and African children under age 5. So examples that might be relevant to you all as end user populations could be married couples in patrilineal societies, queer adolescent girls in the rural Midwest, or newly cohabiting men working in time-intensive occupations. And so, market segmentation may just be inevitable for such intersectional and interpersonal technology as MPTs. This framework can also be useful when you're wrestling with the problem or the issue that individuals may shift in and out of being end users for a product as their biological and interpersonal needs change. But there's always going to be a group with those characteristics, and you can think of that as your target audience. So contraceptives and MPTs have much in common with other preventive behavioral interventions. These images are from the CDC's website about diabetes prevention, and the images show people eating fresh produce, getting physical activity outdoors, and keeping an eye on their body mass index. Healthy habits keep us well and help us maintain our bodies. But unlike treatments for disease, healthy habits take place without the emotional valence of getting rid of an illness, and thus they are hard to adopt and hard to maintain. We all know that we should eat right and exercise. People know what they are supposed to do. They know that they should use medications or devices to maintain sexual and reproductive health. But products and counseling about them can be designed in ways that increase or decrease the chances of successful use happening. So who is going to use this intervention? What are their preferences, their needs, their social constraints? And I'm going to touch briefly on adherence to medical regimens, on some concepts from behavioral economics, and on the conduct of clinical trials. So understanding behavioral factors influencing adherence to medical regimens was one of the goals of the recent NIH Science of Behavior Change Common Fund program. The first stage of the program sought to improve our understanding of basic mechanisms of human behavior change across a broad array of health-related behaviors, and to use this knowledge to develop more effective behavioral interventions through 3 broad classes of intervention targets: self-regulation, stress reactivity and stress resilience, and interpersonal and social processes. So the first representative project that I have listed focused on the use of medications and devices in adolescents with type 1 diabetes. Self-regulation, which is the capacity to control one's thoughts, emotions, and behaviors to reach a desired goal, shapes health outcomes through many pathways, including supporting adherence to medical treatment regimens. In the case of type 1 diabetes, these daily treatment regimens can be arduous and effortful. For example, monitoring blood glucose requires active effort multiple times a day. Adolescents generally demonstrate poor adherence to these regimens, yet it is essential that they assume increased responsibility for managing their type 1 diabetes as they approach young adulthood. So this project used behavioral interventions to improve self-regulation in this population as a novel method to improve treatment regimen adherence. The second SOBC project listed looked at episodic future thinking, or EFT, as a way to reduce delayed discounting, which is the psychological preference for smaller, immediate rewards and associated maladaptive behaviors. They examined the effects of an EFT exercise with and without a named specific health goal on rates of discounting demand and craving for cigarettes and fast food among cigarette smokers and obese individuals, respectively. And they found that the addition of a specific health goal to a more general EFT was significantly associated with a higher impact on the participants' subsequent demand for cigarettes and fast food. So another effort that may provide useful material for enhancing the behavioral and social science aspects of product development is a current panel from the National Academies of Science, Engineering, and Medicine on future directions for applying behavioral economics to policy. So behavioral economics combines information about human behavior and outcomes with more standard methods of economic analysis. Behavioral economics has been applied in various contexts, such as individual decision-making, nutrition policy, housing and health insurance, and addressing addictive behaviors. It is increasingly influencing standard economics, as well as commercial and public policy objectives through its many applications. So some of the concepts that are addressed in this report, and there's a report and there are more ongoing efforts, including additional webinars. So first is limited attention, which considers information constraints that individuals face that may make their choices look less than rational to those who don't understand their cognitive framework. Inaccurate beliefs are understandings that stem from incorrect or partial perceptions of situations, incentives, one's own abilities, or the beliefs of others. Present bias reflects the human psychological tendency to prioritize what's right in front of us. An example is the marshmallow test, if any of you are familiar with that experiment. Reference dependence acknowledges that people evaluate options relative to an existing starting point, usually the status quo. And it's related to loss aversion, where people would rather stand pat where they are than risk a setback. And lastly, social preferences and norms acknowledge that we care about the opinions and approval of others beyond what we ourselves prefer and think is the right thing to do. So how do these factors play out, especially in terms of behavioral interventions? So here are two examples from the report that are relevant to the use of MPTs. The first is or both of them are from the section on promoting preventive care, HIV prevention and transmission. The first example addresses the limits of attention in varying contexts. In a setting with substantial HIV prevalence, HIV prevention requires sustained attention and motivation. If the salience of HIV risk is low, limited attentional resources may be allocated elsewhere. The second example addresses present bias, again, similar to delayed discounting, the tendency to settle for a smaller reward that is available right now over a larger reward that will not be available until some point in the future. And present bias, relevant for all prevention behaviors, may lead to procrastination or avoidance of short-term hassles or time costs if people underweight the future benefits of prevention. And if you remember about 5-10 minutes ago, I was reading a quote by someone about the hassles of going to get an IUD. So finally, in the same way that medications and devices are tested in randomized clinical trials, so are behavioral interventions. Behavioral scientists have spent a great deal of effort developing innovative methodologies for conducting clinical trials to deal with the complexities of people going about their business in the everyday world. So one example is the SMART design, sequential multiple assignment randomized trial. So this study here attempted to optimize an adaptive intervention to increase rates of testing and adherence to New Jersey state COVID-19 recommendations. Testing, social distancing, quarantine, hospitalization, contact tracing, and the acceptance of COVID-19 vaccination and booster shots among high-risk populations. Participants completed a baseline survey and were randomized to receive navigation services or an electronic brochure. They then completed a follow-up 7 days after baseline and were re-randomized to either continue with their original assignment or switch to the other intervention or critical dialogue or brief counseling. This design allowed for direct comparisons of the impact of an intervention aimed at individual barriers, critical dialogue, and an intervention aimed at structural barriers, navigation services. And I know that discontinuation is a big issue in product development. So this is how you can actually possibly incorporate it into your design. So one final comment on populations is that it's important to think about representation in your clinical trials. Overall, NIH is part of the current necessary focus on the inclusion of underrepresented populations in clinical trials. Your research faces a polarity when considering who needs to be represented. And by that, I mean there's a tension in the gap between who could be using your product and predefined visions that you probably already have in mind of who your end user populations are. Going back to the social science of how people use technology, people will always surprise you with their creativity. Fertility preservation technology research was designed for cancer patients, but there's been uptake among other chronic disease populations, as well as persons who simply aren't ready for childbearing due to relationship or other career considerations. Adjustments to the behavior patterns required to use a product effectively or how a product is presented to patients or providers may open up an entirely new group of end users or close the door to one that you thought was part of your process. So I hope that these ideas inspire you to search out behavioral and social sciences research colleagues and bring them fully into your collaborative teams. I've tried to provide hyperlinks to resources and publications throughout the presentation, and there'll be a PDF version of this presentation with those active hyperlinks for distribution afterward. And I've also included 2 pages with additional citations and food for thought. So here's one on some of the intersectional topics from the NIMHD framework. and then just some readings on health behavior theories, and a really interesting issue of the International Journal of Epidemiology that talks about really what you mean by representative sample, whether they're a good thing or an appropriate thing to do depending on how you're thinking about your research. So thank you for your attention. I'm really excited for Teri's presentation and the Q&A afterward.
Great. Thank you so much, Roz. And we are going to ask people to hold their questions to the end and let Teri take it away.
Great, thanks. I appreciate everyone's patience as I share my slides. Great, actually, let me switch screens here for a minute, I'm sorry. Okay, can you see the correct view for my slides?
Yes.
Great, thank you. Well, thank you so much for inviting me here today to talk about behavioral science methods to understand end user preferences to inform product development. As a program chief in the Division of AIDS Research at NIMH, I've worked closely with several of the NIH-funded HIV clinical trials networks, as well as overseen a portfolio of externally funded research. So I've seen a variety of different approaches to understanding end user preferences to inform product development. And I think many of you will be familiar with at least some of the approaches that I talk about today, but hopefully you'll learn of some new approaches as well. So I wanted to start at the very beginning with what is an end user? Well, in short, end users are the people who use the product. So for an MPT, and particularly for MPTs focused on contraception and HIV prevention, which is often the space that I've seen MPTs in, you probably immediately think about women who might use the product. And obviously they are very important end users. But I want to encourage us to perhaps also think about providers. Maybe we could consider providers an intermediate end user because they're not actually using the product, but they do have to prescribe it and in some cases administer it. So if we think about, for example, long-acting injectable ART and PrEP, patients no longer have to worry about daily adherence. That burden has been lifted from patients, which is terrific. But when we did that, some of that burden shifted to providers who now have to find the time and the space to administer the product, as well as to ensure patients return for follow-up injections. And we might also think of partners as an end user, although this might depend on the specific product, as well as whether or not someone wants to involve their partner. So for women, some may actively choose to involve their partners in decisions about MPT use, making their partners end users as well. Other MPTs might be felt by the partner. For example, there were some reports of this with the dipivering vaginal ring, or the product might impact sex in some way, again, making the partner a potential end user as well. What are end user product preferences? What do we mean when we talk about this? Well, a big one is product type. So we could talk about rings or pills or injections or patches or implants or gels or films. But beyond product type, no matter what the type of product is, there are attributes that might be seen as important. And this can include things like whether or not the product can be used discreetly without other people knowing. The frequency of use or the dosing regimen. Is it used daily, monthly, only before sex? The side effects, the impact on fertility, as well as potentially the length of time to return to fertility after stopping the product, and the impact on sex or on the vaginal environment. And then finally, there are also important physical properties that might be really product specific. So for tablets, one important factor is the size of the tablets. For gel, the viscosity or how runny or thick the gel is might be really important. And for ring, one of the characteristics that came out as important was the hardness of the ring. So why should we even care about end user preferences? Well, I think probably the most important reason is that we want to develop products that people will use. Even the most efficacious product isn't going to prevent a single infection or a single pregnancy if no one uses it. And we think that people are going to be more likely to uptake and adhere to a product if it really includes or addresses some of their preferred product characteristics. But beyond thinking about this, I think it's also important to think about adherence during clinical trials. So some clinical trials have been hampered by low adherence, which makes it difficult to determine product efficacy. So if we design products that meet user preferences, perhaps we'll get better efficacy estimates during these clinical trials. And then the second important issue, I think, is cost. So a couple of points about this. We should work to understand and, where possible, address end user preferences early on in product development, because it can be quite expensive to change a product's properties after it's been approved. We don't want to find out after approval that there's one easily changeable facet that people don't like in the product. And then also, obviously, the reality is that there's limited money to invest in products. So perhaps we want to focus that money and invest in types of products that are preferred or that have attributes that people prefer. Because again, it's very expensive to develop and test a product that no one wants to use. Where do end user preferences fit in to predict ultimate uptake and adherence to a product? Well, here's one model which considers product characteristics as one component of product acceptability. And you can see some of the product characteristics circled in red in this model. And product acceptability is one of several factors that influence use. So there are other influencing factors you can see on the left at the individual, household, partner, and structural level. And Roz touched on a few of these in her talk. And then finally, the product alternatives influence which product is ultimately chosen. So what other products are available for people to use? And I also want to note that it's possible here that the choice might be to use no product, even if there are products available. I hope I've set the stage for why we should be thinking about end user preferences in product development. And now I'll switch to talking about how we might assess end user preferences. I'll talk about 5 ways that researchers have gone about this. Qualitative research, these are standard interviews and focus groups. Human-centered design approaches, discrete choice experiments, assessment of user sensory perceptions and experience, and placebo trials. And there is some overlap among these various methods, and many of these methods can and have been combined. For example, qualitative research, interviews and focus groups, is a component of many of these methods. And not everyone would have segmented these methods the same way I did. But to me, these are 5 distinct approaches that I wanted to touch on. So probably the most utilized method for assessing end user preferences is qualitative research. And this involves asking people about their preferences through interviews or focus groups. Participants might be presented with pictures of different options or might be given a prototype or several products that they can hold and feel. This qualitative study here, conducted by Ariane Vanderstraten, used qualitative interviews with women participating in a vaginal ring trial for HIV prevention in Malawi, South Africa, Uganda, and Zimbabwe. Women were presented pictures and descriptions of different product formulations and asked about their product preferences and factors that contributed to these preferences. And they found that participants preferred long-acting HIV prevention products, including rings, implants, and injections, due to the continuous protection they offered, their ability to use these products discreetly, and lack of worry over missed doses. Participants did not prefer oral tablets, largely due to daily dosing and HIV stigma. They also did not prefer gels and films, particularly young women, due to the need to insert the product vaginally, the potential impact on sex, and lack of familiarity with these types of products. So this qualitative study provided really important information about the types of products that women prefer and some of the attributes that are important to women in HIV prevention products. For each method that we want to talk about today, I want to briefly highlight some of the pros and cons. This is not an exhaustive list, but just some initial thoughts. So I think there's a reason that interviews and focus groups are one of the most popular methods for this type of work. They're very flexible. They can be used at any point in product development, and they generally don't require a lot of resources to conduct this work relative to some of the other methods that we'll talk about. And I think particularly for very new products that no one's ever used before, they can be really helpful in helping us understand novel product specific attributes that might be important that might not have come up in work with other products. On the other hand, although interviews and focus groups can be used at any point in product development, they're often focused on initial reactions without specific product experience. And then there's also the potential for social desirability bias, which is really true for any method where someone's going to be interviewing and asking questions in person. People might want to please the interviewer, and so they tell them what they think they want to hear rather than their actual thoughts. And they might not feel comfortable bringing up criticisms of the product. So another method that's been used is human-centered design. This often uses qualitative methods, but I think the hallmark that distinguishes it from the types of interviews and focus groups that we just talked about is that the end users and developers work together to co-create products. And there's a cycle of inquiry where people find out about the needs and work to understand the context of the end users, to ideation, which is brainstorming, where you rapidly come up with product ideas. And then there's early prototyping and rapid testing of those early prototypes. So this is really a cyclical or iterative process. It's not linear. And I was challenged to find an example of human-centered design for HIV or MPT product development. Maybe we can talk about this at the end. Maybe someone in the audience will have some good examples. I did find a lot of examples for development of behavioral interventions or packaging or product or service delivery. So this example is actually the use of human-centered design to develop a multi-component behavioral intervention to support youth living with HIV in Mozambique. The team first conducted research with adolescents and other stakeholders to understand and identify barriers and motivators for ART adherence, and that was the inquiry phase. Then they held ideation sessions guided by how might we questions. So this was things like, how might we destigmatize HIV to increase retention and adherence? And through this process, they generated hundreds of potential solutions. And then they went through a process to narrow down and determine which ideas to focus on. And then in the prototyping and rapid testing phase, they worked with adolescents and other stakeholders to develop prototypes, had participants interact with the prototypes, and obtained feedback to further narrow down and improve these prototypes based on feedback. So you can see here in the figure on the right-hand side, there were several components that they thought were pretty much ready to go and be included in the pilot, things like some radio ads and pill containers that they had developed. There were other options they wanted to include in the pilot, but really needed to get additional feedback and refine those more, things like parent and peer support groups. There were some options that they decided to put aside for now, but come back to later after the program had more maturity. And then a few things that they decided to completely leave behind, primarily because they were concerned that those might inadvertently out someone as living with HIV. And then they worked to test these prototypes in a small pilot with plans for a larger trial to test the whole multi-component intervention that includes the options in the two sections on the right. In terms of the pros of this approach, I really appreciate the centering of end users in this approach. They're bringing end users and product developers together so product developers can better understand how the product will be used in the context of people's lives. And this approach is really building on the creativity and the strengths and the insights of the end users. I also appreciate the iterative process that allows for multiple rounds of new ideas and improvement of existing ideas. On the other hand, as you can probably tell, this is a fairly intensive process with these cycles and multiple sessions, which could potentially be expensive. It's possible that participants might ideate products that are not practical or possible, that end up with nothing in those sections to move forward into future testing. And I think that this really requires someone to lead it that has experience in the process of human-centered design because of the complexity of it. So another method to understand end user preferences is a discrete choice experiment. This is a paired choice survey that's administered to better understand potential users' preferences for various products or for specific product attributes. So you can see on the left, here's an example from a discrete choice experiment And what I mean by paired choices is that people have to pick either product A or product B. So for example, would you rather choose a ring that's used monthly and causes heavier bleeding, or a tablet that's used weekly and causes frequent stomach cramps? And this is believed to mimic real-life decision-making because individuals have to simultaneously consider multiple attributes and the trade-offs that they're willing to make between those attributes, as we do in real-life decision-making. In real life, there's rarely a product that's going to combine all of our most preferred attributes. So this particular study was a discrete choice experiment around MPTs, but it had a really novel twist. The purpose was to understand heterosexual couples' preferences for an MPT. So there were 400 couples in Uganda and Zimbabwe that were enrolled. And at enrollment, they first completed separate discrete choice experiments. And then they came together as a couple to complete a joint discrete choice experiment. And overall, the results were a little bit complex, but they found that the frequency of dosing, so whether something was on demand, daily, or monthly, by product form, for example, tablets, insert, or ring, was the most important attribute in both countries. And return to fertility, time to return to fertility, was least important in both countries, with the other important factors actually differing somewhat by country. And then when they looked at the individual versus the joint discrete choice experiment, about a quarter of couples were aligned in their individual choices before they even came together to do this as a joint exercise. And then among those that were not initially aligned, about 21% ultimately aligned with the female's preferred product when they came together to do the joint DCE, and 17% ultimately aligned with the male's preferred product in the joint DCE. And the rest of the people aligned with neither the male's nor the female's preferred products when they came together to do the joint DCE. So as we might expect, there's quite a bit of variability in couples in terms of whose preferences were ultimately the most influential. In terms of the pros of this approach, it may approximate the real-world trade-offs that people actually make. You can consider multiple facets of products simultaneously, and you can do this with a really efficient design. So there are obviously a huge number of potential pairings depending on the number of attributes and the number of different levels of those attributes that you're looking at. But not everyone sees every pairing through this efficient design. And you can also eliminate pairings that it wouldn't be possible to use together. So for example, a precoital implant just wouldn't be possible or practical. So you don't have to include that pairing of precoital and implant in the DCE. On the other hand, this might require a large sample, certainly larger than a lot of the qualitative work. It's unfortunately, there's a dearth of research on whether stated preferences predict real world choices. There's a small number of studies that have suggested that it does, but I think we really need more research in this area. And then it does require someone with expertise to program the survey and to analyze the results. So now I'll talk about some work that Kate Guthrie has termed user sensory perception and experience. And this work tends to focus on one product, but rather than just ask what someone likes or dislikes about the product, there are multiple versions of the product where they change up either one or a small number of features that could potentially be modified during later product development. So for example, in one study, they evaluated 4 topical vaginal gel formulations. Women used all 4 gels in a randomly assigned order with a washout period in between each application. And when they used it, they inserted the gel, they walked around, and they engaged in simulated sex to really understand all of the senses that they experienced during that gel use. And then they responded to survey items about their perception of the product. And this was a very extensive survey. Just some of the things that they responded to were rating the application process in terms of things like leakage, ease of application, and whether it could be used and carried discreetly. In terms of when they moved around, they rated whether they felt movement of the product while walking, sensations of leakage, and sensations of stickiness. And then they also rated whether they could feel the gel during simulated sex, whether there were sensations of wetness, and perceptions of leakiness or messiness. And then in subsequent research, they asked participants which formulation they preferred, and then were able to identify the patterns of sensations and experiences that correlated with someone's preferred products. So in terms of the pros of this approach, if you have a specific product of interest, this can really help you to hone in on some of the very specific but most critical aspects of the product. And this moves beyond hypotheticals to actual product use, although it may in many cases be a placebo product. In terms of the cons, I think this tends to focus on just a subset of product characteristics that are related to user sensory perceptions, and there's less of a focus on other attributes that might also be modifiable and important. And then the last method that I'll talk about today is a placebo-only trial. So in this type of study, participants use the products of interest, but there's no active pharmaceutical ingredient in the products. Often this is done in a randomized crossover design where the order of products for each participant is randomized and each participant tries every product. So this is from the TRIO study, a trial of 3 MPT placebo products, including tablets, rings, and injections, that took place in Kenya and South Africa in women aged 18 to 30. And they were randomized to use each placebo product for 1 month and then could choose a product to use for 2 additional months. After trying each product, injections were chosen most often by 64%, and South African women were more likely to choose injections than Kenyan women. One really important finding from this study is that women's mean ratings of how much they like the product changed after use, with ratings for the ring, which was initially the least familiar product, showing the greatest increase in how much women like the product from prior to use to actually using them after placebo use, which suggests that actual product use might be important in understanding people's preferences. So in terms of the pros of this approach, you're actually assessing real-world experience with the product, not asking hypothetically which product is preferred. You can get semi-real-world data on use and adherence, and I say semi because obviously it still is within the context of a research study. And you can capture initial reaction to the product as well as reaction after placebo product use. On the other hand, sometimes it's difficult to fully mimic a product. For example, placebo products often don't have any side effects, unlike active products with active pharmaceutical ingredients. And this might be an expensive and sometimes invasive method, depending on the product. For example, injections or implants might be are pretty invasive products, more so than a focus group asking about people's perceptions of that. So I did want to have, I know I'm running low on time here, but I did have just a few concluding thoughts, things to consider. If you're going to do this kind of work, it might be useful to obtain iterative feedback during development. This might not only give you better information, but also changing one factor can sometimes have unintended consequences. For example, in some of the ring studies, people really didn't like the hardness of the ring. But in subsequent studies, when there was a softer ring that was being tested, there was more slippage and expulsions, and the softer ring really couldn't be used. So changing that factor of hardness could have had unintended consequences if you didn't do iterative development. In multi-country studies, it's important to note that there have been different preferences in different countries. So really important to consider the context, as well as to consider other key characteristics that might influence preferences, things like age or partnership status. You really want to make sure that you have variation in participants to capture these different characteristics that might influence preferences. We should consider thinking about and involving providers and partners as potential end users. And designing products that people have an initial positive reaction to might be really important for product uptake, but perhaps designing products that people have a positive reaction to after use might be important for adherence and persistence. So maybe we want to look at both of those things. And then I just want to point out this NIAID-led funding opportunity for MPT development, and NIMH has signed on to co-fund behavioral science integrated into MPT product development. And then there's an upcoming webinar, and I'm happy to post the details in the chat if anyone is interested. And this is Chelsea Solmo from USAID. This is a webinar that's being led by NIMH and NIAID, and she's going to be presenting on their design to delivery process for incorporating end user perspectives into HIV prevention products. And so whereas this talk has been really a 30,000 foot view of how you could go about doing this, the upcoming webinar on February 1st will be a really deep dive into one method that's been used to do this. So I want to thank everyone for their time and attention, and I'm going to turn it back over to Clara.
Great. Thank you so much to both Teri and Roz. I know I learned a lot, and I particularly appreciate that you put some resources so we could follow up. And so we actually have a couple questions. I know Bethany received a question that she wanted to ask. So, Bethany, if you want to go ahead.
Yes, hi everyone. So Roz, I was really struck, by your comment and the slide you put up about, the growing public health awareness and interest in people in disabilities. And I was hoping you could maybe elaborate further on that. This population has actually been identified as a priority, um, population to be addressed as sort of an action area, because it's a gap in MPT R&D. And I think, it's exciting to see that there is growing interest. So I know you have background in that, so I wanted to hand it over to you to see if you could talk further.
Sure. Then I'll say a few things, and then I will post the websites that I reference in the chat. So yeah, I was at the Eunice Kennedy Shriver National Institute of Child Health and Human Development. That institute, NICHD, has been a leader for a long time. Persons with disabilities have been one of the special populations that the institute has tried to advance, and they're also the home to the National Center for Medical Rehabilitation Research, which is across NIH, an NIH-wide initiative. But recently there has been more traction, especially under the current administration, and with a lot DEI efforts have expanded into DEIA, which is accessibility. But some of the specific things that have come out of NICHD include, in 2023, we had a meeting on reproductive health for persons with disabilities in the transition from adolescence to adulthood. That meeting grew out of the most recent strategic plan that the Institute had developed. And that led to an RFA on promoting reproductive health for adolescents and adults with disabilities that currently has, I believe, 3 R01 grants up and running. But more generally, there is also a notice of special interest in reproductive health, pregnancy, and parenting among women with disabilities. That is actually, the expiration date is coming up at the end of May of this year. So I would think the scientific context could let you know if they're planning to reissue it. But all of this is part of just a more general concern now about ableism and how we approach there's research that research has inclusion and exclusion criteria, and sometimes the exclusion criteria are persons with disabilities, and it's not necessarily an exclusion that's related to the research and what's specifically being tested. So the emphasis on ableism is trying to draw attention to issues like that, and to always, for the default, to always be to include, rather than the default being to exclude because it makes things easier. But that's, research also has a broader mission. So I'll put a bunch of those links in.
Thank you so much. Those resources will be great. And we will actually also post those in the, in the SBR, the resource hub on the website and circulate. So thanks so much, Roz. Back over to you, Clara.
Great. So there was a little bit of chatter going on in the meeting chat. It looks like some of those questions were answered, so thanks for that. So yeah, I had a couple other questions that I wanted to ask, and it was interesting when you talked about sort of present bias and delayed discounting. I was wondering, sort of with that in mind, also in both of your research, how much have you seen where individual risk does actually seem to align with user preference for preventative products? So put another way, do people generally seem to have a good sense of what their risk stratification is? Are they wildly inaccurate? Especially for these preventive products, we know that it's hard. It's a lot easier to get someone to ameliorate a condition than to prevent something. So I was just wondering, as researchers, we're frequently looking at populations and trying to stratify, and how much of a match or mismatch is there?
I'm happy to tackle the question about risk perceptions. I do think that often, some people do have a very accurate perception of risk. But I think particularly when we're talking maybe more so about HIV prevention than contraception, HIV prevention is really tricky because it's not only the behavior that you're engaging in, right? So if we think about like cardiovascular disease, that's almost entirely dependent on your own behaviors, right? The foods that you're eating and how much you exercise, and obviously a genetic component there as well. But when we think about HIV risk and sexual behavior, it's not only dependent on your behavior, but also on your partner's behavior. And sometimes that is not possible to know. And other times, people really don't, it's very threatening to someone's relationship to think that their partner might have other partners. And so maybe they would choose not to believe that. So I think risk perception does become a challenge when you're thinking about HIV prevention.
Yeah, I really appreciate Teri's point about the partner perspective. And I would so it's a few years ago now, but there's an anthropologist named Jennifer Hirsch at Columbia who did some really fascinating research on couples where one partner had migrated for work purposes to another country and then came back and using condoms because the partner who did not migrate was like, well, the partner who had migrated took it as an expression of distrust by the other part. Like, what do you think I was doing while I was gone? So you get tied up into these really interesting dynamics. The other thing I wanted to mention as far as knowledge is actually perceptions of fertility. The researcher named Jennifer Barber at the University of Michigan was working with adolescent populations, late 18, 19-year-olds, and found out that, so our message in sex education is if you have sex one time, you can get pregnant. So they would have unprotected sex one time and they wouldn't get pregnant because we know it's actually, a percentage, it's a stochastic process. And then they thought they were infertile. So then they would keep having sex without protection and then they would get pregnant. But the whole area of how much an individual knows about what their actual fertility is. I know that Clara and Bethany, you're in contact with NICHD colleagues in the fertility and infertility branch. And there is research trying to predict fertility in women in particular. And I don't know if they have more up-to-date insights than I have on whether we actually have a test that, a 25-year-old woman can take to assess how fertile she is.
That's a great.
I was going to say, I see that Ariane has her hand raised, and I'm looking forward to her response to this as well. Ariane led several of the studies, the qualitative study and the trio study that I mentioned.
So I was actually going to first thank you for an excellent presentation, both of you. It's wonderful to hear and learn so much about this topic. I did want to bring up two things and get your comments. One is about saliency that Ross, you mentioned, and speak a little bit more about how when we bundle indication, we may actually leverage a low saliency item with a higher saliency item. And I'm thinking that, thanks to the trajectory of the HIV pandemic, fewer and fewer people feel that HIV is a big deal, but it's still a big deal. And how can we leverage, the benefit of bundling indication to try to increase saliency and potentially prevention behavior? And then unrelated to that, but I'm interested in hearing also your perspective around, you mentioned behavioral economics. And there's been a bunch of research that hasn't shown that at least the nudging at the individual level really was that helpful in changing behavior. So can you talk a little bit about the type of intervention where behavioral economics may be the most impactful? And may or may not be at the individual level, maybe more at the institutional level or policy level, but I'd love to hear your perspective on that. Thanks.
Sure. Yeah, those are two really good questions. And but as far as policy and, yes, behavioral economics, it's all about finding the nudge. And it's also about setting the default. So there's been a lot of success, for example, with retirement plans. And where now when a person comes in to their job, the default, it's not that you have to opt in to join in the retirement plan. The default is you're in it and you have to actually opt out. And so one of the challenges for MPTs is, a retirement plan, we're all comfortable with policy for our retirement plans. We're not so comfortable with a default policy that, everyone is going to be handed a contraceptive when they walk in the door. And that actually gets to some of the ethical considerations that I mentioned, where in some cases, they've tried to push in that direction, and it has been done ethically. Because we are talking about policies that affect the most personal of decisions in our lives. So I think looking, it's an area that requires a lot of creativity and a lot of sensitivity. And I don't have a good answer. I do think your mention of systems is important, because when the context isn't so personal, if you can just make things available to everyone, those kinds of experiments have shown a lot of promise, because you're setting up a default situation, but it's not targeted. So it's an incomplete answer. And as far as salience, this is what to me, MPTs are just great, because if what's more salient is I don't want to get pregnant, but you have the benefit of HIV prevention along the way, that seems like a win-win. But yeah, this might be something where Teri has more knowledge than I do.
Well, I don't know that I have more knowledge, but maybe I'll just add a few comments. I was thinking about some of the behavioral economic stuff, and I think one of the key principles of behavioral economics is that inertia is the most powerful force. And so maybe if we can get people to start on an MPT, then that's something that we can, build on that power of inertia to keep them on that MPT. But I do agree that getting over that hump of getting people onto an MPT is going to be challenging. And then I also love the idea of, thinking about not at the individual level, but at broader levels. And it made me think of a study that was done with physicians where they provided feedback. I think it was about how often they prescribed antibiotics for a non-bacterial infection. And they gave them, it was like social norm-based feedback, like, here's how you did, here's how many times you did it, and here's how many times the other providers in this network or whatever did it. And that was actually just a super powerful nudge that really changed provider prescribing behavior. And so I wonder if I think one of the challenges of MPTs is going to be to figure out who is the best person to prescribe and deliver the MPT, right? Is this going to be people who typically focus on HIV prevention, who might not be comfortable prescribing a contraceptive, or is it going to be someone who prescribes a lot of contraception that might not be comfortable focusing on prescribing an HIV prevention product? So maybe if we can figure out who might be the optimal providers for an MPT and incorporate these kinds of behavioral nudges for the providers, I do wonder if that could have a strong effect for a low cost. And then in terms of the salience, I'm not sure that I have that much to add to what Roz said. I do think that's in the HIV field, which is what I work in. I mean, that's the real hope of MPTs and why we're very interested in them, because people do often they are interested in contraception, particularly at early ages, and do want to prevent unwanted pregnancy. And there's a lot of interest in a 2-in-1 product that prevents both. And so I think you're exactly right that particularly in the US, but maybe in other countries, as we see the rates and salience of HIV decrease, it might be harder and harder to get people to take an HIV prevention product. And so if we can bundle it with another product that they're more interested in, like contraception, or we could even think about bundling HIV prevention with all sorts of other products that people might be interested in, perhaps we can get more people taking HIV prevention products because they don't need to do it. That's the behavioral nudge there, I guess, right? They don't need to do anything extra to take the HIV prevention product if it's already bundled into this product that they're interested in.
Thank you.
Great.
That's great. That Teri, that reminded me of, conversations we've had since the launching of the initiative about fluoride in toothpaste and sodium and salt, and how do we, get people to do things that are good, so thanks. But I wanted to, so Meredith asked a great question up here about, let's see, wanting to hear more about your perspectives, Teri and Roz, about what are the key gaps and challenges and unmet need in incorporating meaningful end user research into MPT product development, and how can we build it so that they do come? And yeah, so Meredith, if you have anything more to elaborate on that, otherwise, Teri or Raj, you want to take a crack at that? Thanks, Meredith.
Yeah, I'm
elaborate. Just welcome your insights.
And I also saw Meredith's note about the human-centered design project that Conrad did called Launching B, which is an excellent example. And I did actually look at that as one potential example as I was developing my slides. It's really, it was to develop maybe Meredith, you can explain it better than me, but to develop sort of a suite of interventions around PrEP to get adolescent girls and young women to uptake PrEP at higher rates. But in terms of what are the gaps? I mean, I think actually MPTs maybe are a bit ahead of the rest of the HIV prevention field in terms of incorporating end user preferences. I think some of the work that I cited from Ariane, as well as from Ellie Minnis, who I think was on earlier but had to jump off, is, they've really done a lot of great work to advance this. But to me, one of the biggest challenges that I see, and I would love to hear your perspective on it as well, Meredith, is that we're very siloed. And so there are behavioral scientists and there are product developers, and they're sitting in their silos and they're not coming together to work together, except in a few cases. And I would love to see more. And I think sometimes when we have folks that are product developers that are interested in developing an MPT and would be open to including product preferences, they just don't even know who to call on, who does this kind of work, how to get this started. So I would love to see something where we could bring product developers and behavioral scientists in this area together to help bridge that gap.
I have a problem with my virtual hand. So I was going to, Chelsea may want to add to this, but I think that in a way, the Matrix project is a great example of innovative collaboration with socio-behavioral scientists and different methodological approach as products are early in the pipeline at the preclinical stage. My question, and maybe you do have an answer or maybe not, is that there's a lot of preferences. You end up with a rainbow of preference because some dimension of preference are geographical, cultural, and otherwise informed, but other are very individual. I like my coffee with milk and you don't like your coffee with milk and you want it black and that kind of thing. So it makes it hard to distinguish the important elements of preference that we should act upon and those that would be nice to have that but are not indispensable. And I think that what is hard is to triage among all the things we can focus on, the more important one that will make a difference in terms of uptake, use, and impact on the population. And I don't know if you have suggestion about how to do that better, because I think we don't have that handled very well under control. Thanks.
Yeah, I think that's a great point, Ariane, and it's really hard because there's ultimately one product that moves, that moves forward into development, and so we never end up knowing if these things that we've done have actually had a benefit on that product because we don't really have anything to compare it to. I guess I would say maybe one approach would be to think about who is at the highest need. And maybe that's in terms of like who has the highest rate of, what groups have the highest rate of HIV infection and unwanted pregnancy combined. There's also like for oral PrEP that I think the CDC has developed a PrEP to need ratio. So like what percentage of this group that could be taking PrEP that has an indication for PrEP is not on PrEP. So maybe that's another way to think about it, not just where is the greatest need, but where is the greatest need that's not being currently covered, and then focus in on that subgroup of people. And then I think the other way to manage that is to just make sure that we do have choices. So you're right, there might not be one product that rises to the top, but maybe there are 2 or 3, and we can work to try to develop those to make sure that people have choices in terms of their products.
I want to also, if I can expand to that, and echoing Ariane and the shout out to all the great work that Matrix is doing and bringing those social behavioral scientists and product developers, including the MPT space, together. And I agree with you, Teri. I think that the MPT field does have, I think, a really good head start in trying to understand the end user research as we develop the products. I guess from my lens as a product developer, I think the gap or the challenge really, I guess, that we're all really pushing hard to get to and being mindful of the cost it takes to get there is actually taking those, across the board. These are all more or less first in class MPT products, and getting them actually not just the placebo, but in addition to the placebo, getting the actual first generation product into clinical studies. Because definitely, Conrad takes this approach in trying to incorporate discrete choice experiments, human-centered design approaches, other ways to try and gather preferences and feedback into our products in preclinical stages. Ultimately, and I think the MPT space, I don't think it's going to be as simple, of course, just taking the learnings from the HIV prevention side and the learnings from the contraception side. There are going to be new questions, new challenges, and everyone says, survey after survey say how much that's what end users want, but then actually making sure that they then do come, once the product is there. I think the sooner we get products, maybe the imperfect products, into those phase 1 trials and actually start getting feedback from users, not just the target users, I think will really help to drive maybe some of the questions that we have as we really try to develop, build it. But definitely appreciate this whole seminar, this webinar today, and the insights from everyone to bring us together.
Yeah, those are great points. And a couple of people have mentioned Chelsea and the Matrix project, and I just want to mention that February 1st webinar that I mentioned, Chelsea will be presenting, and she'll give us a deep dive into their boundary breaking process. I think it is really great to see what they're doing in terms of incorporating end user perspectives.
I just wanted to make one comment about actually getting things to people. And just one of the best talks that I heard during the COVID-19 pandemic about vaccinations was from someone in operations management, talking about how we had the vaccines now and it was great. And somewhere up in Boston, in order to get the vaccine, you had to go through a sign-up page with 50 different fields, 50, that you had to fill out. And some people were trying to do this on the phone. We didn't all have laptops. And then to actually get to the site, you know, they put them in places like stadiums because those had the room, but you know, that was hard to get to, especially if you were poor or, you know, lower income. And so a lot of the uptake of things, I know it's like worlds apart from being in the lab, playing with molecules and actually getting something into someone's body, but that end part can just throw out all the work that went into it beforehand. And it's these little things like, how many fields do I have to fill out on a page to sign up for this? That can, again, the hassles, and people will just walk away.
Yeah. Well, great. This has been just such an exciting, really engaging webinar. And I just thank you again so much, Teri and Roz, for taking the time to put this together in your busy schedules and for, you know, your expertise in this. And, you know, I think Meredith made a comment I just want to reflect on again, is that this is an iterative process. It's like the more questions, you know, the more we go forward, it's like the more questions come up, and HIV and contraception. It's not like you can just put them together independently. It's like an organic process. So thank you. So I just wanted to, you know, as we wrap up, you know, wanted to remind you all that as with all past webinars, today's webinar recording will be available on the MPT Learning Events Hub on our website. You can also visit other MPT resources there. We've already mentioned the SBR Resource Center. We have the MPT database. We have a regulatory guidance hub that actually is also you know, relevant to all of the matrix work. And that there is actually relevant to that. There is the Forum for Collaborative Research has actually started an MPT regulatory pathways working group. So we just really welcome you to visit our website, send information. If you see anything missing, you know, send it there. You'll see in terms of past webinars, we've had recent ones, diversifying funding streams for MPT R&D, integrating end user research, and MPT development. And we are planning one, our next one that's scheduled is going to be delivery platforms for MPT research. So stay tuned for that. Next slide. Great. And so here, you know, we just really welcome again your input. You know, are there topics that you think you'd really like to learn more about that we could have an webinar on? You can also just, you know, visit our website. Here's some links. Okay. And next slide. Great. So yes, as I said, the next one will be on delivery platforms. So are there any other final comments or remarks? Otherwise, I think we can wrap up. All right. Well, thank you, everyone. Clara, any more final words from you?
No, I mean, a lot. Maybe I'll just ask one last question to Roz and Teri. If there is, you know, you were very generous in sharing links and noting the presentation coming up. Is there a way that people who are interested in learning more can get in touch with some of the resources that you have, like can work with you, work with people in your branches, or just learn more if they're not able to undertake this research themselves? Maybe you can give them some last parting words on how they can get started in this field.
I'm always happy to talk to folks, and my suggestion for all researchers is to contact a program officer early and often. So if you Google me, you should be able to find my email address if you're interested in doing this work.
And I've moved within the NIH, but I will add a slide into my presentation with contacts back at NICHD who are program officials who people can reach out to.
Wonderful. Thank you all, and hope you have a wonderful rest of your day and week. And yeah, stay tuned and we'll have this posted. Bye-bye.